So there's a problem and we're all here. And so we thought it would be good for this conference to have a solution, but not just a solution, but show you the tools that are actually being used, not information, but actually being used. So Coral and Atlas Billing Company, which I'll tell you about here in a minute, are two of the tools that we present you today, and also how they work together. So I'll describe Atlas. Atlas is a clearinghouse that was established way back, and Atlas serves as the payment receiver for Surgery Center of Oklahoma. So when I posted the prices in 2009, I thought it would be a good idea for a Canadian to just write one check instead of pay surgeon, anesthesia facility, pathology, all that stuff. So Atlas Billing Company receives the payment and then implements that bundle. So we pay every person that participates in that care episode. Atlas morphed when I met a hospital administrator years ago who incredibly came to Surgery Center of Oklahoma and told me she loved what we were doing, and was there anything she could do to help us? You can imagine how suspicious I was, but she was sincere. Her name is Kathy Hibbs, and I said, yes. I mean, you can give me pricing on procedures that we can't do here and send over there. So we started working together. And she made a point early on that was important. She said, we can work together as long as you collect all the money and you pay everyone. She was rightly concerned about being in conflict with her carrier contracts. So when a Canadian came in, when anybody else came in, and they needed a robotic procedure, they needed nuclear medicine, they needed a colon resection, they needed all those things we couldn't do at our facility, then the patient or the third-party administrator, cost-sharing ministry paid Atlas, and Atlas paid Deaconess Hospital, the surgeon, paid everybody. So that sort of grew, and we were able to work with many facilities with this, basically creating a contact with the CFO at a hospital. We usually knew which surgeon was going to be involved, and so we just curate, in Greg's word, curate these bundles. Kylie Mays is in the room. I saw her a second ago. There you are. Kylie basically runs Atlas now, and we run it together. My wife and I, Darla, co-own it. So Darla brought many efficiencies to Atlas when it was being administered off of hundreds of Post-it notes, which is how I did it. So the Atlas is now paying hospitals and providers in multiple states. And I'm able to actually secure good pricing. I think part of the reason for which is that when I ask someone for a price, they know I'm not a fool because I know what kind of the pricing ought to be. So we tend to get fabulous pricing almost without exception. So that's Atlas. We develop new bundles. I don't know, we probably create 20 or 30 new bundles a month. When I get a bundle from a hospital, I was explaining to someone last night, when we get a bundle from a hospital that we're working with, we ensure that they're okay with that going forward. So if somebody else needs a hemicolectomy, I already have that price. And I know unless the hospital has let us know otherwise, I can use that and actually quote that price going forward with confidence. We cloak everyone that has carrier contracts who's scared to death of Blue Cross and the rest of them. Because if they offer us a price more favorable than that in their Blue Cross contract, then they have issues with Blue Cross. Those fears are unfounded but understandable. We help patients get to where they need to go. If it's in an unusual market for us, like in Phoenix or somewhere else, I typically will reach out to a primary care doctor in that area and ask him who would do your hernia surgery. You wind up getting the same surgeon's name when you make that call 3 or 4 times, and you know who the patient ought to go see. Because we manage and create all these bundles all the time. Atlas is just second nature to us, and some of the things I think other people struggle with bundle implementation it's our normal. And it's as weird for people to think about Atlas as it is for me to file a Blue Cross claim. I wouldn't even know how to do it. So Atlas and Coral work together. Whenever someone looks on the Coral platform, which you'll hear about here in a minute, and there is not a price or a bundle for a certain procedure, then that's where Kali and I go to work, and we just create a new bundle. And that's how new bundles happen, is when there is a request that's come through for the first time. Atlas and Coral together, therefore, is a very symbiotic arrangement, because once people realize, because it's not listed on Coral as a bundle, once they realize, well, this is how new bundles happen, they can still happen. Once they get to that place, then the power of Coral and Atlas working together is verified and shown on an everyday basis. Any questions so far? Wow, I've been clear. Okay. I think it's yours.
What is Coral? That's an existential question.
On what you just mentioned, Dr.
Yes.
So you said that the fear of the providers in terms of the payer contracts, the insurance contracts, you said you cloak providers, and it's lower, in Atlas than what they negotiated with the payers. So why do you feel that it's unfounded, their fears?
Well, the fears are unfounded because the money that a carrier sends to a hospital or a doctor is not the same as the money that Atlas sends to a hospital or a doctor, because they know they're going to get it from Atlas, and they're going to get it in a timely fashion. So money 90 days from now is not worth as much as money now. So because the payment terms are so favorable and so assured, with no possibility of clawbacks or all the other insanity that the carriers do.
It's not adjudicated.
It's not adjudicated at all. I mean, the way we work, we ask a hospital, how much do you want for a hemicolectomy? And they're real careful, because they know if they don't give me a good answer, because there's no haggling. It's just, give me your best price, one and done. If they don't give a good answer, we're going to go somewhere else, and they know that. So they tend to answer with a good answer. Their fears of the carriers, though, are unfounded because of the time issue, because they're going to get their money, and they're going to get it fast. They also don't have to chase the patient around the kitchen island to get their deductible. It's 100%. So there's no part of the payment that is pursued. So that's why I think it's so different that their fears are unfounded. You agree with that?
Yeah, but they're still afraid.
They are afraid. Okay, Greg Smith.
Okay, so what is Coral? Coral is a direct contracting platform. It is also a marketplace. I think that to kind of cut to the chase, the key elements of Coral are that on the payer side, it provides all the functionality required to manage direct contracting, from locating and discovering through various search and comparison of the possible providers and possible bundles and services. It provides the mechanism for generating the referral, for issuing a voucher if that's the methodology that's being used. We accommodate dozens of different sequences. Some payers don't issue vouchers or agree to pay until there's a scheduled date. Others issue it at the time it's sent as a referral. You have instances where it's an emergency room scenario and there's an emergency room carrier on the platform and the voucher is issued ex post. The point being is that we've learned through time from a architecture standpoint to facilitate all of these different methodologies and sequences to accommodate how payers, are operating their plans and their intermediaries and their various subagents, right? So, some plans have a TPA that only pays. They have another third party that does care navigation. Some use DPC that needs to be integrated. Others, the TPA is providing all of the services from an integrated standpoint, managing all the inquiries, all of the redirection or navigation, really, payment, complete control of the plan. All of these various forms of structure we facilitate. But the biggest thing that we've done and learned over the last 5 years is, and this is, kind of cuts to the heart of what Coral is about, is, having a price really is kind of a meaningless concept in free space. All prices have attributes. It's where, it's what, it's when, it's if it's implants, the elements. Some bundles, the implants are included. Some implants, the bundles are a separate charge. Some are a direct pass through. Others kind of hide it. We essentially trust ultimately that the market clears, and by having all the terms and conditions, both the attributes of the bundle, the contracting attributes, all aspects, and standardizing the payment processes, within the existing domain of the world, that enables now a price has meaning, right? If I compare a price for a total knee to here in Dallas or Fort Worth, I guess where we're at, to one in Oklahoma City or one in Houston or one in Vegas, now it has meaning because you can, examine all the attributes. So that's our kind of biggest event. On my slide here, I say, we have the economic free lunch counter. I think most everybody here is aware of the fact that in healthcare, at least 31% of every dollar is basically administrative cost. Could be more. Some people argue it's only 26%, but what is always excluded is also the transactional friction that's imposed on the patient, all of the hidden friction, one of the things I'm struck by when we work with ambulatory surgery centers especially is the degree to which, the difference between Surgery Center of Oklahoma and another facility is typically that the other facilities have a mixed book of business, Medicare, carrier business, and bundles. And their whole processes organizationally are completely defensive surrounding versus Surgery Center of Oklahoma, where they document things and impose costs in the OR that are only there for one purpose, which is if they get audited or if they are reviewing, they have to be able to defend everything they've done. And it's just imposition of cost, and it's, it doesn't help the care. It doesn't even make the OR more organized. It just adds another person that's standing there like a checkout counter that's, doing the card reader for the inventory control so that they can comply with the rules. So the point is that there is all this direct cost that basically Coral is aimed at reducing. And, our guess is that if you were 100% on Coral, which is, there's like 4 people I know of, virtually all of our customers run a mixed book on the payment side. But if they were 100% on it, basically would strip out 2/3 to 3/4 of this kind of blob of cost sitting in the middle, because we eliminate all of the various, sources of external cost, internal cost, to the extent that on a typical provider, we have one big provider that does 300 cases a month that went from having, when we first started doing business with them, they did 100 bundle cases a month. They had 3 people involved in billing and scheduling. Now they have half a person and that half a person actually only spends a half a day each week pushing the button on the screen that auto-gens the invoice from the, and adds the ICD-10 and the date. So, that's what Coral's about in a nutshell. So you've made this grand decision to, in your plan, to utilize bundles. And so it's kind of now what, right? I mean, you can modify your plan, you can have navigation team, you can have all kinds of engagement, but you do actually have to find somebody to perform the service on a bundle price basis. And, how do you find them? And then when you find them, what happens? So we put together a few real cases that literally are in the last 4 weeks that will either run directly through Atlas or will run through Coral. And in each case, the starting point was these were all pretty much from indemnity and sharing plans, not commercial plans. But the left-hand number is the number that the patient was quoted on a cash pay basis when they were talking to the facility saying, hey, I'm going to pay cash. And the right-hand number is what was actually paid in the actual surgical procedure. And I think this is you.
This is a patient that came to Atlas, the people looking for help. I think this patient had 7 previous hernia surgeries for ventral and incisional hernias. So, incision all the way, and it had all failed. It had all come apart. So they came through initially as a ventral hernia repair. Well, that's like $4,600 on my website. But the more we looked at the records, we realized, oh my God, no, this is an inpatient case. The patient's probably going to have an ileus and need to stay in the hospital. So I had one of our general surgeons who works at an inpatient facility look this over, and he began to tell me what was going to be involved. And it was going to be probably a 5-hour surgery. The patient was going to stay in the hospital a solid 4 days. And they were traveling, and they had been quoted $125,000. That's just a facility charge, so that's actually not a correct number. That didn't include surgeon anesthesia and the rest of it. And it also was an estimate, because if he'd stayed more days, then there would have been even more. So 125 is kind of a conservative number to look at. Kylie reached out to inpatient facility we work with, where this extremely talented general surgeon that we work with goes to, and all in, his fee, hospital fee, anesthesia, and we didn't give this. We asked them, how much do you want for this? And they knew what they were getting into. And wound up being $22,750.
I have a question. Is there, and since that it had been failed hernias before, does any of that price include if there's complications or it did not work again with that? Or is it?
Yes. So we work with one hospital that gives us 2 prices. And bariatric surgeons do this. They say, here's the price, and then here's the other price in case anything goes wrong. So a hospital that we work with, they give us a price that would apply to either a self-funded plan beneficiary or cost-sharing ministry, because they know if something goes wrong, and things go wrong, even when you do everything right, there still is kind of a safety net. For a cash buyer where there's no safety net, then they give us that other price. And then they just bank that. And they're not going to quote a procedure they're not good at because they're at risk. So the quality is baked in. But that number for that hospital includes if something goes wrong, really. This happened to be a member of a self-funded plan, and everything went great. So had a happy ending. This one's yours, isn't it? Because that is much more than I charge. This may have been a gallbladder surgery that Atlas purchased at a cooperating facility, because our price.
This is actually done in Frederick, Maryland.
Frederick, Maryland.
Right.
that didn't go through Atlas then. This is a Coral example. Yeah, I'm 58, 65. So.
Oh, we couldn't get him to come here. What can I say? Yeah, so basically on this one, this is an example of, Troy probably knows the details better than me, but in essence, the payer, discovered, had the case, it was referred in, the patient, had a quote that was, $18,000, I think probably actually more. And, they came to us through the payer, actually the payer's representative, the navigator, and they got on the system, located this ASC in Maryland, and basically, sent a referral, all the processes all the way through, and payment ran through Coral. And to put it in a sense of scale, in Coral, there's about, right at the moment, 420 ASCs, a like number of hospitals, 4,500 imaging locations, and I think there's 1,000 PT. The point being is that there's lots to go from, and frequently, it's the case that, in our relationship with Atlas, basically, there's always the edge case, right? So we have bundles for all the things that normally happen, but, what normally happens is basically 1/3 to 40% of all cases. So the other 60%, somebody has to engage, and it's either Keith or one of the other kind of curating providers we work for. Occasionally, they'll reach out and contact one of the providers and ask them to, agree to a single case agreement. But the problem with that methodology, when it does involve, Keith and Atlas, is that I'm not a doctor. None of my guys are doctors. I look at all this stuff, and I know how to organize it and build a market, but I actually don't know what's on the piece of paper technically. And the reason I say this is it turns out that a very large segment of care navigation is populated by people. There's nurse navigators, which is one category, but a big chunk of navigation is kind of in the same step, which is if it falls into a certain domain, right, they can do a great job, but you get a couple of steps out, you really have to have somebody involved who can curate. Not only that, just match this case to the right guy. I mean, I have 30 orthopedic groups in the platform, but that are not all equally applicable to every case. And so that's where Atlas comes in, and we work closely with them on those scenarios.
And so this 10.7, that's for the surgery bundle, that's not including the travel.
That's the savings.
No,
the savings.
that's the
Okay.
planned savings.
Sorry.
The procedure was 7,300.
7,300.
And there was no travel because it was local there.
Local, okay.
Right.
Yeah, and keep in mind, big picture too. I mean, when, as Jay mentioned this morning in his opening remarks, the reason FMMA exists is we wanted these sort of free market principles to expand. I mean, he didn't want to get huge and franchise, and I didn't either. I wanted to help others copy what we were doing. But as requests came in for procedures that we could not accommodate at Surgery Center of Oklahoma, I felt it was my place to try to help the clients and buyers, whoever it was, individuals, cost-sharing ministries, self-funded plans, help them find all the care that they possibly could get. So ironically, some of the people we pay are the very hospitals that tried to put Surgery Center of Oklahoma out of business, and they are now Atlas's vendors. So I now pay them, and shockingly, all of the legislative attacks and all the other insanity just kind of goes away because now they find it beneficial to be part of this. So the market is, as Rothbard says, it's beautiful, but it's also powerful. So Atlas is one of those tools that has brought these price gouging hospitals into the game, kicking and screaming a little bit, but they're beginning to understand that this is an okay way to do business, an alternative payment model, and Atlas is the tool that lets them do that. So it's kind of a big picture thing. Also, it's important to really grasp the people that did this for $7,300 are better at it than the people who said $18,000, because you can't say $7,300 instead of $18,000 unless you know what you're doing. So the price is baked in when it's bundled, and here is the price. Because if they're not good and they do it at $7,300 and something goes wrong, nobody buys from them anymore. Fixed, gone.
Do you guys do the research beforehand, like on the outcomes of that surgeon? Or?
The way that I pick surgeons in the local area, if I'm unfamiliar, is I'll ask one of their colleagues that I do work with, who would do this if it were you? I had a discussion this morning with Brian Klepper because he said, you need to have your data out there. And I said, well, that is a data point. I would argue, if I called my brother in Lawton, who's here, and ask him, who would fix your hernia? I actually know who would fix his hernia. But if I ask him, he would tell me who it was. And it's because he sees patients who had hernia surgeries who came back to his office, and then he knows if they're happy, if they've done well, if they've been revised. So the industry's always had an ombudsman, an advocate for patients who is their guide over the bridge under which is filled with trolls, as I've said before. So
let's move on to our next one, because I think there's one in here that's my favorite one. Is this
Do
it?
you have a question, Eric?
Yeah, Dr. Imes?
In 2005, Medicare had a question, and the question was, how do hospitals arrive at their charges? And so they empowered a group called the Levin Group to study this. Came back, they make it up. So the question is, when you're negotiating a bundle with one of these hospitals, the hospitals clearly have no idea what they're doing. How do they arrive at a number? You help them, you kibitz, you tell them what is a reasonable price, and they can decide to take it or not. Because I can't believe they have the intelligence or the knowledge to come up with a price. I've asked them in the past, and I've had to work with them. I used to be a medical director for 30 years at Integris. I asked him one time, what's the CBC cost? Do you think they had any idea? They had no idea.
No idea. They use Medicare as a rule. So we walked through this process with Deaconess Hospital for years, and they gave us prices, and it was like pulling teeth. I need a price. This patient, this needs a price. Come on. And so it was just plotting. And then they looked back and they realized, what we end up quoting you is like 140% of Medicare. So why don't we just give you a price list of 140% of Medicare and go with it? There's another hospital in Oklahoma City now that is doing that. And we pulled teeth with them for a while. And then they thought, well, to streamline this, why don't we just give you a super percentage of Medicare for the facility side? Keep in mind, Medicare is not a legitimate benchmark for most surgeons and most anesthesiologists. So you have to just sweep that aside. Medicare is completely illegitimate for most physician services. 1,000% of Medicare, the anesthesiologist is probably underpaid, frankly. It's just the last total knee I did, $78 for Medicare. It's illegitimate. But for the hospital, Dr. Imes, they're using some super percentage Medicare, and they're making money. They're making money at 100% of Medicare unless they're buying Super Bowl ads and all their competitors and all that stuff. Is this the one you were thinking about?
No, it's the last one. It's the ablation. This is my favorite.
Yeah, we worked together on this. This one was fun. You want to go through it?
No, you
So, patient needs a cardiac ablation. $100,000 is the first fee. Called Baylor, Scott White. Too bad for Scott White that Baylor bought him. $80,000 cash pay. Called Cardiac Hospital. They said $36,000. Got another price for $36,000. Kylie and I called them, and the one that posted 36,000 sold it to us for 24.5, and they made money. The reason I knew 36,000 was too high is I called a cardiologist friend and said, how much should the facility charge? And he historically knew where they had been on cash prices and quotes. So we kind of went into that knowing ultimately where they would end up. But yeah, it's 24.5 all in by an extremely talented EP cardiologist that I would recommend to anybody in the room. But I like all of you. So
The key reason that it ends up 24.5 is, and we've had some similar cases just when we call up and get something, is the reaction to a patient who they know you're not a knowledgeable counterparty is the 36 number. You get the 24.5 when they know that the counterparty on the other end of the phone knows what the price is and knows what it should be. And, they basically cut to the right number, right? So that's kind of, the side key is, and, that's why, Atlas and Coral are now, do a lot of business is partially driven by that. It's the counterparty knows we know the answer. And, my guys will just quote to the guy and say, wow, but, you realize that this is done at 10 other facilities at price X. Are you sure you want to try to charge $36,000? That would be our answer.
right.
So
Another interesting thing about Atlas and any sort of bundle arrangement is while I have an understanding with surgeon, with our anesthesia group, which I'm part of, about what their fee should be, what portion of that bundle should be remitted to them. If a surgeon, an orthopedist, for instance, tells me, for that case, I'm going to need $200 in Synthes screws for the hardware. This happened last week. He spent $1,000 on implants, but I'd already quoted the price based on his telling me $200. I never go back to patients for more money because that mistake is on our end and it was on his end. So the bundle didn't change, but his portion of it did. So kind of strike one, and the surgery center then splits that mistake with the surgeon, but the surgeon pays price. Another thing we're able to do, we looked at what we were paying for implants for total knees, and it was all over the map. Some of them were $5,200, some were $1,800 for the components. And I can't look at Jay Kempton or anybody else and say the $5,200 implants are better than the $1,800 implants. So there was just this range. These are great surgeons and great outcomes, but the real number, the top number really was about $3,500. So I threw out all the little ones and I threw out all the huge ones and picked $3,500. And I told the surgeons, if you spend more than $3,500 on implants, then I'm just going to take it out of your fee. Well, that's all I had to do because the reps at 5,200 knew that surgeon was never going to call them again. So all of their prices came in to $34.99. So when you have control of the bundle and you have an understanding, but the understanding also is that they'll be good for their part of it. If they don't deliver, then the bundle has that power, and it's a price control mechanism in itself. Questions? Yes.
So I think you just answered my question within that discussion right there. But I presume that you're discussing you mentioned that surgeons are way underpaid at Medicare and anesthesiologists, et cetera, are way underpaid. Are you counseling with the surgeon before, in order to include the right price for the surgeon in the all-inclusive price?
Yeah, this my favorite conversations to have with a surgeon who's never done this, because we just ask them, how much do you want? What? I mean, they don't have a clue. And so they come back and they give me a price, and it's not enough because I want them to be ecstatic when I call them with a referral, because the patients pick up on that. This patient knows this surgeon is really happy that I'm here. So they give me a number, and I said, well, if you're happy with that number, you'll be happy with the number I had in mind.
Well, if they're doing cardiac ablation on me, I want them to be happy.
You want them to be happy. That's right. Yeah, and if the surgeon doing the abdominal wall reconstruction for 5 hours, he now tells me, listen, don't call me. Just assign a fee, because whatever you come up with is going to be so much more than I would possibly think I deserve. And I mean, he's phenomenal. So after a while, they just let me quote their fees. But it comes down to time and expertise. So if it's a 4-hour case, I kind of have an idea of, what sort of nightmare that is for a surgeon who's fast and efficient. That's a big case. Yes.
Hi, so is this all cash pay? Because you're talking about reps, and then the hospitals who are fighting with you. So is this also patients who have insurance?
This is all, and he does like guys who show up at the front desk and pay him. In my world, it's 100%. You're either in a self-insured plan, it's indemnity insurance, it's sharing ministry. I only do business with people who are part of an organization. I do no retail. You can't call me up on the phone and say, hey, I'm Bob, I need a hernia repair. I'll say, it's great news, Bob. Are you like Bob the company? Or Bob? That's Bob.
Bob the builder.
It's Bob. I would send it to him, because we don't, the reason is that in my world, most of the facilities still refuse to allow their prices for bundles to be published publicly, right? There's only, there's some that are posted online, but, it's a growing number, but I think it's probably fewer than 30 facilities in the United States that actually post real prices, right? There's lots of prices floating around, but like the real prices that's an executable number.
Right, not
other
this
than him, Surgery Center of Oklahoma is like one of the few. So
why do you think that's still the case?
why is that the case? Because life is short, and if I were these guys, I wouldn't want to have to argue with the guys that represent 2/3 of my revenue, even though they're a lower percent of profitability. So if a facility did, unlike Surgery Center of Oklahoma, like I said earlier, most of the ASCs that we deal with, the bundles might only be 15% of all surgeries they do in the facility, but it's usually like 30% of profitability. And they just don't want the brain damage of dealing with Blue Cross. And the way they react to them is that if they get called on it, they say, well, I'll give you the same deal if you pay me within 14 days, you don't adjudicate, and, the deal's the deal. You don't fight me on this thing. Yeah, you have the same deal. Of course, they can't do that for a variety of reasons, right? One of which is all their ASOs, the guys that are the sales guys in the ASOs make all their money on percentage savings, so that doesn't work, right?
So the question still remains, like, for you, Coral, if I'm an employer, because it sounds like you were saying, like, okay, well, Atlas is the individual and you're the group.
Surgery Center of Oklahoma is individual. Atlas is like us. He's dealing with companies principally and other intermediaries. But I'm not sure what the question.
I was asking if it's self-insured, or if it's cash prices, or if it's insurance prices.
Okay, so it's kind of neither in a sense, right? So the word cash prices, unfortunately, is kind of it means one thing in Keith and Maya's world, and it means a completely different thing in the hospital. So a cash price at the hospital is a number that the guy will let you leave and clear the bill, which, it's whatever the guy will negotiate. And if you're smart enough, you can actually negotiate with them, right? Their recovery rate is 2% of cash pay. If you show up and you don't have insurance, or you say you don't have insurance, and they have to treat you, and then you negotiate about the bill, you can beat it down. But of course, the starting number is like $15,000 if you like break your arm, right? Maybe more actually, 30,000. But they'll take 3,500 if you give them, pay them right now, right? But that most people don't know that, right? How many arms do you break, right? And who would you call to find out that that's a number? In our world, the price is already negotiated, you know. And the most important thing to know in this space is, if you do not make the deal ahead of time, you will not get the right deal.
I guess all I'm trying to figure out is who's paying you. Is it the
I get paid by the payers, the insurance company, and not the insurance company, but the self-insured plan. Right? I don't get paid by the individual.
Okay. The administrator of the plans. Okay, so the person who administers that plan for an organization, or a company or a shared administrator,
TPA, shared
that company's.
Yeah, exactly.
We have time for about one more question.
Is it true the surgeons make more money than your employer?
Yeah, multiples. Yeah, so for a $3,740 knee arthroscopy, the portion of that goes to the surgeon is more than anybody else pays it. So, yeah, they love it.
Do you know roughly on that same procedure what the hospital would pay that surgeon?
Throw a number against the wall.
Good type plan?
Ballpark.
Ballpark. Surgeon told me the other day he received $315 for a knee arthroscopy that took him about 45 minutes, and he's pretty fast.
And
And
that's
they bill-
usually 90,
What's that?
paid 90 days later. After
He had to fight for it. So $315 for a knee arthroscopy by a talented orthopedist. That was Blue Cross.
Well, he's separately billed, so he bore the cost of, you know,
Right.
his bill. So he sends in the bill to the clearinghouse, and, you know, he goes into the ether and shows up to the guy, and they say, okay, we'll give you 300.
That's right. That it.
Okay, y'all join me in giving a
Thank y'all.
to this.